These are the outtakes, obviously. So there's this guy Scribonius, who's some Roman character, and as I'll show you in the next slide, he's the first person to get into electrical stimulation of the brain. But there was some work done around the 1870s, and this had to do with the functional localization of the brain. And if you remember those kind of skulls that the phrenologists have, where they write on this bit of porcelain what each bit of the brain does, completely fanciful and complete rubbish. But this was the first attempt to try and get it right. So people would, they do this a lot of the time in animals as well. And what you'll see is that this really reached its zenith in about the 1950s, and that's a guy called Wilder Penfield, who's responsible for the Penfield homunculus that you know. And his neurophysiologist was a guy called Herbert Jasper, and this was in Montreal in Canada, in a very famous epilepsy unit that carries on to this day. This is said fish, and it's a torpedo fish. They used it for treating headache and gout. So if you had a bit of a headache on a particular day, you didn't go and see this guy, because you get a slap around the face with a fish, a bit of a shock, and that would be you. And it's a torpedo fish, and the term torpedo then translates into torpid, at the state that you're in after a heavy meal or something. That's where the term torpid comes from. There's another guy, and you must look this up on YouTube if you get the chance, a guy called Delgado, who again in the 60s, he's a Spanish guy, worked variously in Yale. Some of his experiments are a bit more dubious, and they did a lot on animals, and they did a fair bit with the primates, and did a lot on in the psychiatric world. But there's a marvellous YouTube of there's a bull that he's put an electrode into the caudate nucleus, and he does the toreador bit, and then he stands there with his remote and switches it on, and the bull stops. It's a brilliant YouTube video if you've never seen it. Perhaps more dubiously, he was into psychiatric work, and he was doing a closed loop experiment in chimpanzees, so he'd record from the amygdala there and the hippocampus, and then stimulate their central brain, provoking an aversive reaction, thereby preventing them being agitated. And this is kind of the early kind of part of psychosurgery, you might say. And they discovered that if you stimulated various areas in the limbic circuit, you could induce a euphoria. Some of this electrical work was actually done in Liverpool on primates, and a guy called Harvey Cushing, who, if you know heard of any neurosurgeons, you'll have heard of Harvey Cushing as in Cushing's disease, and he in Liverpool, on behalf of Sherrington, stimulated some of the great apes, and you can read some of his work on stimulating chimpanzees and orangutans to work out which bits of their brain did what, and that was done in this very town. This is Victor Horsley, who's kind of one of the fathers of British neurosurgery, and that is his stereotactic frame, which looks very small, and of course it is, because it's designed for a cat, it's not designed for a human. And this moves on to the history of deep brain stimulation, with these characters, Spiegel and Weiss, at the end of the just after the war, and then working through these guys. And what these guys did was that they developed a stereotactic apparatus by which they could put electrodes into particular areas of the brain, and they would then explore the brain, trying to find areas of the brain that they could stimulate in order to arrest certain functions or to worsen them. And very roughly, low-frequency stimulation, which means around about 4 Hertz, will stimulate something, and high frequency, which means around about anything over about 60 really, will inhibit. And they identified lesional targets because they had no hardware, no technology that they could deliver chronic stimulation with. And this went up to about the 1960s. And they'd use it typically for Parkinson's disease, the tremor of it. This is the kind of, as it were, the golden age of this. This is Spiegel himself. This is their stereotactic frame, which is now human size, and was actually based on Horsley's original frame. Then along came levodopa, and that finished it all. Everything stopped, and levodopa was used to treat Parkinson's, and stereotactic lesional surgery virtually died apart from one or two individuals who kept going with it. But it then became apparent that there were problems with the drug treatment, and with time the patient would become refractory to the drug and they would develop problems from it. And dyskinesias, this kind of writhing movement that you get as a side effect of dopa agonists. And at the same time, and you get what are called on-off fluctuations. So the patient is on when they've got too much drug on board, off when the drug wears off, and when the drug's on, they have dyskinesias. And so the drug treatment of Parkinson's isn't, in the longer term, very successful. Similarly, new material sciences came along, and this is roughly about the time of the advent of cardiac pacemakers, and the technology within a cardiac pacemaker is not that dissimilar to what you need for deep brain stimulation, and it delivers an electric charge in a regular manner. And it was then developed for spinal cord stimulation. And it turns out that the company that were approached for this, Medtronic, had made its name in cardiac pacemakers, and so the technology was readily transferred across. And the first deep brain stimulator was done by this guy, Hosobuchi, really quite a long time ago now, but it was actually done in the thalamus for pain, which we'll come back to, although it's not now the common use for it. Locating the target, we've all seen the revolutions in imaging, and it's now hard to recall back to a day. It's really only about the 1980s, the mid-80s, actually if I dare say it, when I started in neurosurgery, it just was about the time of the introduction of CT scanners for all hospitals. But it used to be that a patient would come to the Neurosciences Centre to have their CT scan because hospitals wouldn't have them. And the idea that you could MR scan everybody was also pretty unusual as well. And of course, computers, because there's an awful lot of calculation involved in all of this. This is some of the old imaging that you would have pre-CT days, and that, believe it or not, is a ventriculogram, and this blur here, well, there's a little arrow, is marking out the third ventricle, and from that you find the anterior commissure, posterior commissure, and you measure up where you're going to find your target. And that is how these pioneers of it blundered around trying to find exactly what they were doing. And they would have very, very meticulous, but you would have literally diagrams like this. You'd be measuring things up with a ruler, and there wouldn't be any computer involved at all. Not even a slide rule, if you can remember what one of them is. Now you get, this is an old-fashioned scanner, but you put a patient through the scanner. The patient is anaesthetised to keep them still for better quality imaging. This is an MR scan, and you can see now, you can suddenly see masses of detail. Anterior, so this one is conveniently labelled, anterior commissure, posterior commissure. What those structures actually do, nobody can quite remember, but they're important landmarks for something called the Tyler Atlas, and based on the anterior ACPC line is called, which is the top right one, is a reference to where every structure in the brain can be found. And then this is it, computerized on the right-hand side. There's a computer atlas with the Tyler grid imposed upon it, and from that you can calculate where you want to be. And here you've got the various subnuclei, the thalamus drawn out, up here the globus pallidus, interna and externa, and as you'll see, those form targets for deep brain stimulation. The improvements in surgical technology. This is a variety of stereotactic frames, and this is a very old one here. These ones across the top are more modern, and this is the stereotactic robot that we used here for a number of years. And they get ever more sophisticated in terms of their engineering precision and their lightness, because the patient has to carry the frame on their head, sometimes away, and it has to be fixed securely to the patient. The pins that you use, which are these things here, going into the skull, they also want to be radiolucent so that they don't obstruct images. And there's a lot of detail that goes into the engineering design of these things that you might not at first sight appreciate. These are now the electrodes that are used for chronic implantation. That's the connector end of it. Top left is the business end, which you can just about see has got 4 little contacts on it. And that actually goes into the brain. conveniently, that is it. That design of electrode hasn't changed now for about 10-15 years, but that's all about to change. There's a revolution in this. It is actually not a trivial thing to change the design, because it has to go through a process of CE marking and approval by the regulatory agencies, and every little bit of it, every little change that you make requires a massive amount of testing, and they will sit with these devices in labs that the companies have, testing these things to destruction to simulate the repetitive strain injury that they get through being implanted in a human being chronically. And over about a 5-year period, when you have these devices implanted in humans, about 25% of them will experience some kind of a disorder or fracture or wear and tear over that period of time. And it's just little things like you have a helical coil here of 4 wires for each electrode, each with a little soldered joint in there. And so they're actually quite a complex thing to design and manufacture, which justifies some of the cost of them, which is about £1,000 for one of those. This is an older type battery. The battery this is a 4-channel battery, just with this is an 8-channel battery designed to run 2 electrodes. You can see roughly the size of it. It's a permanent battery. There are now devices that you can recharge through the skin, and the electronic programming of these things is getting more and more complicated or complex. And although these ones are only 4-channel devices, the devices now exist not for the brain. You can now run up to 16 channels. Spinal cord stimulators now going up to 32. And the discussions that we're having with the company are: should we build in more redundancy? Should we go up to 68-channel devices, 128-channel? And of course, our answer is yes. Of course, you must be mad not to build in the redundancy, because you're going to need it and you're going to be able to use it. So, drifting on back, the advent of the chronic stimulation, 1 or 2 people around the place, Jason Bryce and Lindsay McClellan, people down in Southampton, one of the early publications back in the 1980s to suppress tremor by high-frequency stimulation. But the name that everybody will know is this guy, Alain Benabid, who he's from French North Africa originally, moving into work in a place called Grenoble. It's a very nice place to work, because it's nice to the next to the Alps. And he's the guy who's really introduced deep brain stimulation for movement disorders. And this is one of his early papers, in this case stimulating one of the thalamic nuclei known as the ventral intermediate, known as VIM to all of us in the field. And that's essentially one of the motor nuclei of the thalamus, and that's used for suppressing tremor. There's another group of people, and this is a mate of mine, Tipu Aziz, working with Alan Crossman in Manchester, and they did a lot with the monkey model of Parkinson's, the famous MTP designer drug that he got from California, which turned out to give monkeys, and I think 1 or 2 Californians as well, drug-induced Parkinson's disease. And although you couldn't experiment on the Californians, you could on the monkeys. I think they got that the wrong way around, probably. And that showed that you've got in Parkinson's a hyperactivity of the subthalamic nucleus as an important target. I think the theory of this actually goes back further than this, because I can remember being taught this at university before, which was actually sadly way before this. And so that became a target for Parkinson's disease, where you could treat the tremor of Parkinson's, you could treat the rigidity of it, and you could treat the bradykinesia. And bradykinesia of Parkinson's is this state where you are unable to initiate a movement. And you see the Parkinson's people with mask-like faces, and they can't move about and they can't do anything, and they literally become switched completely off. And that's eventually, in the natural history of it, what kills them. And I think this Oliver Sacks's book, isn't it, about waking up, and they will not breathe properly, they'll get pneumonia and all this, and that's the mechanism of them leaving. So he published this, which is kind of a landmark paper with Patricia Limousin, who's now a neurologist London at Queen Square, and Alain Benhamid, and between them they published this, which was a landmark in that it set off subthalamic nucleus stimulation. The subthalamic nucleus is that thing there, and that's about maybe 5 to 7 millimeters in height and about 2 or 3 millimeters in diameter. And so that's the target that you have to aim the electrode at. So if you imagine now that you're outside the skull and you want to poke a wire in that direction and arrive there, that's the technical challenge. And this is the lot of us that set out to do this around about year 2000. And the indications that we've looked at, now so far in Liverpool we've got down to all but the last one, so that Parkinson's disease, dystonia, tremor, multiple sclerosis tremor, epilepsy, which we've just started doing, pain we've done for some years, and the psychosurgery side of things we've not touched, although there's lukewarm interest from the psychiatrists around over that. And we've got enough to do without getting too involved in that. Why the basal ganglia? Well, there's the kind of the physiology that you know about their importance in movement. But it came about actually by an accident. And this slide kind of has in it all the various targets that we used for treating tremors and such like in historical times. And they would go and ablate areas of the brain, which would stop the tremors and stop everything else as well. Internal capsule, the basal ganglia, the peduncle, and then down in the spinal cord, you would actually do a cordotomy and cut the movement, the corticus spinal tract. And again, it would stop you moving at the expense of the hemiplegia. These guys that were chopping things out in the brain, they had a significant mortality from this kind of operation at that time. It wasn't kind of for the faint-hearted. And this one by Irving Cooper in New York, it was. He was trying to do make a cut in the peduncle where the spinal fibers are, but unfortunately he clobbered an artery called the anterior choroidal artery, which is one of the ones you're not supposed to clobber because it essentially takes out the basal ganglia amongst other things and gives you a stroke if you do that. By some unfortunate that happens. You get aneurysms on the anterior choroidal artery, which is where we see it now. And so they sat up all night with this patient and observed afterwards that the patient had actually got better from their tremor, and that provoked an interest in that area. So then exploring the thalamus, and the thalamus is a difficult area because it's got two nomenclatures, one that comes from animal work and one that comes from human work. And this is really the human nomenclature that's familiar to all the clinicians. And the ventral intermediate nucleus, so which is roughly is the motor nucleus, lying in front of the sensory nucleus, which we'll come to later as a target. And that's used as a target for tremor. It's actually a very good target for tremor. And so tremor-dominant Parkinson's, although Parkinson's now almost always gets a subthalamic nucleus stimulator, the central tremor, miscellaneous midbrain tremors, and the tremor of multiple sclerosis. And very roughly you can see this is not from our unit because we don't have access really to this kind of technology, which would be useful if we did. And this is kind of looking at the situation when you can show improvements in the tremor, putting accelerometers onto the limbs before and after turning the stimulator on. The clinicians get the patient to do this. So you say to the patient, draw a spiral inside a spiral. But before they're trying to do it, they're hopeless, absolutely dreadful. And after they've got the stimulator turned on, it's really quite good. When you put microelectrodes into the VIN, you can imagine that this is a tremor cell going off. And that helps you with exploring the brain for the target. And this, if it doesn't take too long, should work. It's supposed to activate.
If you bring the cursor down, it might pick up the taskbar.
That's it. I need to do it once. So this is a guy who has, you can probably agree, he's got an obvious tremor. And this is always a good laugh. If you get a patient to do this. And you can just imagine this guy kind of serving you wine in the restaurant bar. It's not. And this is the spiral that he's drawing. And now, hopefully, that's him with the stimulator on. And I think you can see there's kind of a bit of a dramatic difference. He's still got a little bit of rest tremor, but that's a whole pile better. And of course, these people, they have a miserable time of it because they can't even drink a cup of tea without, the little kiddies thing with the top on it and sucking it down a straw. And there was one guy we did, and his ambition was to have a whole pint, because previously he'd been having half pints in pint mugs, and it was a bit kind of humiliating for him. And there was another guy who went out and he bought himself some fish chips and peas, but not mushy peas. He wanted the ordinary ones because now he could actually pick them up without them going around the room. You can do it in multiple sclerosis. This is something actually we've written quite recently. And then globus pallidus, which is a target for dyskinesia, which are these funny movements, sometimes gets used in Parkinson. And the key to this is that you're trying to get them to tolerate the drug so you can give them more of it, not to necessarily reduce the drug. And it also works for dystonia. That's the globus pallidus. You can see it on the scan. That's actually somebody who's had a lesion. And this is, again, the dystonia, if I can try and make this work. So this is this horrible, distorted, contorted movement. The neurologist is getting in the way, as usual. And they're sometimes so bizarre you wonder if it's for real. Good. So I don't want to do it, but anyway. Whether it is, but okay. So we'll try and get this. Anyway, when she's had the other video, she's obviously better, otherwise I wouldn't have brought it along. And it's traditional in talks not to bring your failures along, you bring the successes. This is somebody with cervical dystonia, in other words, the neck is twisted around by contortion of the sternomastoid, amongst others. They often have a trick movement. Here it says she touches the side of her forehead, and then she can turn her head round. In these cases, you have to wait quite a long time for the stimulation to take effect, so it's not instant. But this is her later, and she's now not quite as bad, although not perfect. A lot of the time, the indication for doing this is the pain of the dystonia. It's not that they look a bit stupid with their head turned around to one side or feel stupid. It's as much the pain. So the ones that are picked for this, there are generalized PTD as primary torsion dystonia, and there's a gene that they have that the neurologists rule over, because when they've got that gene present, then they're more likely to respond to stimulation. I don't know that it tells you terribly much about the etiology of the condition as things stand. So obviously you have to have a severe disease, it's got to be refractory to treatment, which usually means things like botulinum toxin, although that's a focal treatment, not so good. Some dystonias are responsive to levodopa, so you try to make sure And there are a number of focal dystonias, of which cervical dystonia is one example, and another one is, for example, is writer's cramp. There are some secondary dystonias, some metabolic ones, some tardive ones, that's due to drugs and syndromes, post-traumatic sometimes, and they're quite good choices. So that's kind of the second area that we do most of. So tremors, and then we move dystonias, and then finally this is Parkinson's disease. And this is the subthalamic nucleus that's been of interest now since Alan Bitt's paper. There is the subthalamic nucleus, and doesn't help much with the dyskinesias because that's due to the drug. So the goal here is to try to improve the underlying symptoms and then to be able to reduce the drug. The tremor of Parkinson's is not usually a major phenomenon. Rigidity, sometimes referred to as cogwheel rigidity, and akinesia or bradykinesia is a better term, literally meaning slowness of movement, and that refers to the slowness of initiation of movement. And that's probably the biggest disability of the Parkinson's disease, and one that's fixed by levodopa. And if I get this to work. So this is a guy he's got the typical resting tremor of Parkinson's. You can see he's got a flat face, and he finds difficulty with initiating any movement. And this is him being evaluated preoperatively. So he's really quite disabled. And this is testing him for rigidity. So that's kind of rotating, supinating and pronating his arm to feel the resistance and the catches as you're doing it. And it's difficult to see from watching somebody else do the examination, but it's demonstrating his rigidity. And this, he'll be asked to flick his thumbs like this and can barely do it. So he's got barely difficulty to, and that is a bit of manual dexterity. And you can imagine that if you can't do that terribly well, it's going to be very difficult for you to actually do any of your normal activities at all. So whether that's pouring yourself a cup of coffee or writing or anything, it's absolutely impossible. Eating, of course, is another problem with all of this. And so it's really quite a disability. Try to work out how to move the video on a bit. And again, he's got that very, very expressionless face, completely blank, and that's a feature of it. So it's smiles. And everything's slow. It's said with these people, if you provide a big enough stimulus, they will naturally overcome this bradykinetic phenomenon. So, for example, if you stuck him up in the middle of a road with a juggernaut coming, he can get out of the way perfectly normally. But it's kind of only the experiment we only do it once. So it's supposed to be true that you can do that.
I guess it's the dopamine and the motivation.
Yeah. And he's obviously got a stimulator, so he has it switched on. Even that's difficult. There was some poor bastard who had one of these in the south of the country, and as soon as there was a woman actually, she had it in her handbag and was shopping at Sainsbury's or somewhere, and some tow rag came and nicked her handbag, plus the remote control. And Sainsbury's don't have spare remote controls. So Susan. So his tremor's a bit better. at rest, you can't see that happening now. And his hands are nice and still. And in general, he's moving around a lot more briskly. And if you believe that, his arm is now moving more quickly. Alternatively, the neurologist being more visual. I'm afraid that the medical science is pretty non-quantitative about these things. It would be good to quantify some of this. Okay, it doesn't look normal, but it's a little bit better, and that's better. It is also fair to say that you should think of this not as a curative procedure, but as a palliative one, so that you're probably not going to change the course of the disease, although there is some hope that you might a little bit. But you're not going to what you're going to do is to make the symptoms a little bit better to live with for a number of years and extend the quality of life perhaps 5, 10 years or so. And hopefully he's now going to show that the thing to do is to not so much watch his walking, but watch the speed at which he turns. And if you remember, that's a lot brisker than it was, so he's kind of lost the bradykinesia and his kind of drugs have come back. So, how you do all of this is all about localizing the target. So on the face of it, this is pretty straightforward. You drill a hole in the head, and you get one of those wires, and you just poke it in the brain in the right place. So that's it. That's all it is. As surgical procedures go, it's not technically very difficult. It's kind of one of the easier neurosurgical procedures. It's not like taking a tumour out or an AVM or clipping aneurysm or something like that. This, as technical things go, is relatively easy. But the trick to it is obviously to get the thing in the right place. That's the difficult. So where is it? You can try and target anatomically, and that means you either can see the target using imaging, or you can find it with reference to an atlas. Neurophysiologically, we can use microelectrode recordings, which is what we tend to do here, and then clinically, which is you stimulate and see what happens. And at the end of it all, that's the gold standard, and the outcome is what you get. So really the gold standard, have you got it in the right place, is are you able to record a video like that of a successful outcome 6 months, a year after the event. Indirect is you relate it to known reference points, which are in these various atlases, created by a number of different people, of which the Scholtenbrand Atlas and the Talarak are the most famous. There is another one that a guy called Sid Watkins made, and Sid Watkins will be better known to you as the Formula One guy, who died, I think, last year or the year before. And he did actually do some neurosurgery once. Not a lot, to be honest. He pissed off a lot of his colleagues by pissing off the races all the time. So this is the ventriculography that I showed you earlier, but now it's really done with a mixture of CT scanning, CT because it gives you a true image, whereas the MR scans can be a bit distorted. And there's the AC-PC line, which we can use for looking at the various atlas components. And if you look at this one, you can see the thalamus, which is this area here. It's very difficult to distinguish any targets here, although here you can see the globus pallidus. So two of the targets, the globus pallidus and the subthalamic nucleus, can be seen. But for the VIM, it's done from a stereotactic atlas, and there are lots of, this is sometimes called voodoo neurosurgery, because nobody quite knows what we're doing. And you use these kind of fudge factors, so you measure the AC-PC line, and then this is called the modified Guillot method, and we trust it despite probably being French. And the location here is a distance that is 4/5 and of the distance of the AC-PC line. Lateral is about 50% and about 1 to 2 millimeters above it, and that's the correct target then for VIM. And there are a number of other methods of doing it. Some people say 10 to 14 millimeters from the side of the ventricle, because some people, the ventricle is quite atrophied, and so you go after that. GPI is easier because you can actually see it, and that lesion is placed actually in it, so you can see it there. And we tend to do GPI and the subthalamic nucleus with a mixture of targeting from the reference points and from being able to see it on the imaging. The imaging can get quite concentrated as to how we do it. And this slide is from when we were doing it on a 1.5 Tesla magnet. And there was a lot of trouble when we went to getting the exact parameters of the scan correct. And we scanned for a very long time to get better resolution. And so it's a GA scan so the patient doesn't move. And it took nearly 3/4 of an hour to get these scans done. Yeah. Nowadays, the MR sequences are improving, the field strength is improving, and there are now kind of magnets that you might be able to resolve the subnuclear hypothalamus with. The 7 Tesla stuff that you're doing over in Nottingham you could use for that. You could repeat the scans to try and improve the signal to noise, and you can repeat the MR experiments to try and improve the signal to noise. And then you can directly target the nuclei. The subnuclear hypothalamus we don't routinely do. There is interest in doing diffusion tensor imaging and fiber tracking down to the correct place. And then there is the issue of, is the target localized, or is the target defined anatomically, or is it defined physiologically? And what I said before, it's an empirical answer, which is it works when the symptoms are improved. And some of the times what we do then is we'll work backwards and say, this is where the electrodes are in the people who've worked, and where is that target? And for the subthalamic nucleus, it turns out to be just above it, or just within the dorsal part of it. Microelectrode recordings we kind of do in theatre, so this is somebody with a hole in their head. So this is the head underneath all of the drapes, and this is the hole in the head, and this is the microelectrode going down towards the intended target. And we advance the microelectrode by millimetric distances, and then we can record the cellular activity from individual cells through this microelectrode.
And these guys are awake.
They can either be awake or asleep, either. And then you get typical patterns as you move down. So this is as you come down through the various nuclei. This would probably be thalamus. So if you imagine you're moving down this way, and then this here is a typical firing pattern from the subthalamic nucleus, and that would tell you that you're in that would be an indication that you're in the correct structure, and that you're going to place the electrode at this equivalent depth to that microelectrode. If you go for the globus pallidus, I haven't got I need another scan to go with this really, to show you that the optic tract and the optic fibers lie just underneath it. And this is an ordinary EEG. And with the eye of faith, you can see that there's a burst of activity here and here. And this corresponds to a light being flashed in the patient's eyes at that point, showing that their occipitally EEG goes up. And this is a visual evoked response recorded from the same microelectrode, from the visual evoked from that pathway, again indicating a correct position. What we're doing now is we're using, and I've shown you the robotic frame. This is the frame that we're using at the moment, which is a frame that screws onto the patient. It's a disposable frame which carries the microelectrode and is targeted with an image-guided system, of which this is a part. These are the infrared reflective spheres that locate the geometry of that particular construct. And the infrared camera, the coordination of that is quite accurate. It's accurate to about something like 1/10 of a millimetre in its own right. There are many more inaccuracies built into this that have to do with selecting to target the imaging and the engineering construct of that tower. So overall, the accuracy that you get down to is about 1 to 2 millimetres, but the infrared system on its own is much better than that. And that's the microelectrode going down. The microelectrode recordings once more. And this is actually a lesioning electrode here, and this is a patient holding out their arm with a tremor. So the lady in the pink hat is talking to the patient, as if they're saying, hold up your hand, and the guy holds up his hand like this, and when you stimulate it stops. And it's actually wonderful to watch. It's quite awe-inspiring, and in this case you don't make a lesion at that point. And that's deep brain stimulation. And you finish it off by burying the wires in the head. You tunnel them down to above just below the shoulder, and they put the battery in and connect it all up. And then this is a crappy old picture of a programmer, but then you can program the thing afterwards. With the more modern devices, you can actually charge the battery through the skin as well. If you charge the battery through the skin, there are two advantages. One is that the battery is a lot smaller, and the second is that you can generate a lot more power, because these batteries have to last about 4 or 5 years, ideally before you want to change them. Whereas the rechargeable ones, this is the patient programmer, the rechargeable ones, you can obviously let them go down over a period of about 1 to 2 weeks and then redo them. So we've gone from, in that original historical slides, the ablation, now through to stimulation. Is there a case for going back to ablation? And last 2 years ago, we were talking about this, and there might be advantages to going for ablation. It's a single procedure, and you don't have any of the follow-up required for programming or anything like that. So if somebody's disabled or they've got distance to travel, it might actually be better. The economists like it because it's dirt cheap. One of these devices, all up, one of the latest and the greatest, is going to set you back about 15 grand for that bit of electronics with the wires connected up to it. It's a bit sad because the electronics in it, in terms of sophistication, are probably less sophisticated than what you've got in your iPhone. But being a medical device, it costs a lot more. But there was interest, particularly in places like Africa, over doing ablation. Stimulation better, you can do it bilaterally. If you ablate, if you do a lesion both sides, for example, a bilateral thalamotomy may well lose somebody the power of speech, which you may feel in some people is a good idea, and you do have to follow them up for a long time. Battery depletion is an issue, and the cost. And the last issue coming out of NHS Central as of this morning, curiously, from Bruce Keogh and friends, is that you're not going to be able to do this because it costs too much. So that's it. Yeah?
Not going to be able to do what?
Deep brain stimulation. We'll probably won't be able to do it for new targets, but they've got to take millions out of the budget. So they're going to find ways to construct it. It's wonderful. So some of the results from this, which I've kind of put together, these are the motor scores, and lower is better than higher. And there's something called the UPDRS score, which is a Unified Parkinson's Disease Rating Scale, and this is on drugs and this is off drugs. Although the on drugs with the stimulator is much less drug than when they're pre-op. Yeah. These are a whole list of different scores that go through, and this is the kind of slide that you produce for meetings with lots of percentage improvement and lots of p-values that are way below 0.05 to show how good you are. It doesn't work terribly well for gait. So if people have got axial symptoms or gait symptoms, it's not so good, and similarly posture and stability. So that is a relative contraindication to doing the stimulation, but the improvements in things like bradykinesia and so forth are well worth having. The so-called off-period fluctuations are eliminated because the stimulation is continuous. Similarly, the dyskinesia, because you bring the drugs down, and this shows you how much you bring the drugs down. So apomorphine is another type of levodopa for practical purposes, and the percentage change that they come down, you can see these figures on the right, and we use some kind of garbage equivalent called a levodopa equivalent dose, meaning you take apomorphine and you convert it into the amount of levodopa it would represent if you gave it, and that brings these drugs down a lot. The economists like this because this saves an immense amount of money and actually justifies the cost of the stimulator. But in terms of quality of life, it's a very good thing. And a modest improvement in this thing called the activities of daily living, and it proves very, very difficult to get a meaningful quantitative measure of somebody's improvement in their quality of life that would be observer independent. Actually measuring that is actually very difficult. And there is more recently some further work, and this is to do with the timing of intervention for deep brain stimulation in people with Parkinson's disease. And it turns out from something called the PD Surge trial that we ran in this country a few years back now, from some data from a group in Peel, that the earlier that you intervene, the better the results that you get. And almost certainly we have got a large number of patients that should be treated sooner than they actually are. And the Birmingham group have this year published a paper suggesting that in the people who are stimulated earlier, they have a greater longevity, they live longer as well. So that although I said right at the beginning this is not felt to change the time course of Parkinson's disease, but merely to palliate it, it is probably the case that this does also produce an improvement in survival, which again you think would be a good thing. So I don't know what the time's got to now, because this is either a natural break here, or I can kind of...
We've got about 8 minutes.
I can run through where we're at with the pain stuff. I'll very quickly go through the pain stuff then. I'll just... So there was an interest in treating neuropathic pain, principally this one, post-stroke pain, which is very difficult to treat by any method. Curiously, it turns out that deep brain stimulation is actually good for failed back surgery syndrome, but you'd never use it because you'd always use a spinal cord stimulator. Intractable, you can have a discussion about what intractability is, whether it's drugs or whether it's any of these other treatments, but generally deep brain stimulation has been feared by the victims and by the referrers as really the last throw of the dice, and don't send anything for this, it's never going to work. Of these targets, sensory thalamus, the central median nucleus of the thalamus, the periaqueductal periventricular gray, which is the naturally descending endorphin modulated system that inhibits pain. Cingulate cortex is recent, and that idea there is kind of an emotional one, which is pain is an unpleasant sensory perception. So what you do is you leave it as being a sensory perception, but you just change the unpleasant bit. So no longer does the patient think it's unpleasant, is roughly the idea of it. And it's very, very close to psychosurgery, which is where we kind of came in, if you like. The thalamotomy for pain used to be used for cancer, was originally the reason for inventing the gamma knife, but not really terribly popular, with not that many people responding. And nowadays the medication for cancer is so much better that it's not really got a place. That's roughly where this is. So the sensory thalamus and the periventricular, periaqueductal structures. This is where the cingulate is, and where you would do the lesion or the stimulator for that. These lesions did have complications, and there is always a risk of hemorrhage when you do this, and that's why doing it for relatively benign conditions like pain is much more difficult than doing it for Parkinson's, when you know you're dealing with a progressive condition. Yeah? There aren't the evidence that any of this works for things like pain is rubbish, which is good news for the commissioners and the people at the moment, because they just say there's no evidence, we're therefore not going to fund it. And a guy called Robert Coffey in about 2001 reviewed all the American experience and found the percentage of cases that got more than 50% pain relief at 2 years was only 13%, And as a consequence of that, the FDA in America said that's it. No more DBS for pain, it doesn't work. And it's had a bit of a revival, really, because of the move with deep brain stimulation for Parkinson's coming alive again. And a guy called Robert Levy looked at a series of cases, a 13 series over about 1,000 cases, and said, no, it is a bit better than that, and it's worth looking at again. And so people have been doing, with some success, but not massive. Tipu Aziz, whom I mentioned earlier, he's quite keen on it. He's slightly worryingly, he's shifted target from the sensory thalamus periaqueductal braid to the cingulate, which is always a little bit worrying when somebody does that, because well, rightly moved, probably because the first target didn't work, so why should the second target now work? So I think this is jury out on this. These are some of their data on it. So I think that's probably about right. There's weak positive interest indications in some of these indications, but for the ones that we're really concerned about, those stroke, we're not kind of that impressed by at all. I'm going to flick past this in the interest of time. This is, and then just leave you with the last indications that we've been doing, and this is for epilepsy. So we're now kind of in a totally different disease spectrum. So this is people with intractable seizures. Somebody who has intractable seizures has a reduced life expectancy by virtue of that. So it is actually a life-threatening condition, not simply an irritating one. And in these people, there's a thing called the Sante trial, which was a randomized trial, and the group treated got a seizure reduction of 40% compared to 14% control, and they actually had about 10 to 13% of them seizure-free, which doesn't sound terribly good, but you have to remember that these are people for whom absolutely everything on the planet has failed, and to get any of them improved is actually quite a good idea. Another target is the centromedian nucleus, and that's been used successfully by the King's group for generalized seizures. We've done one of these, we've done about half a dozen of the anterior nucleus ones, and we've got so far encouraging results. And the subthalamic nucleus can be used if they have kind of motor seizures. Psychiatry, we haven't done any, but there's quite a large interest in this. The Belgians have a group doing this, and the group in Dundee is interested, and I think Bristol and King's have done some of these. The companies are massively interested because under the category of treatment-resistant depression, each GP practice will have maybe 1, 2, 3 of these cases, which represents megabucks to the companies in terms of their business plan. Whereas something like Parkinson's disease is actually very rare, and it doesn't have anything like the market, but this does. And again, people have looked at anterior internal capsule, OCD is obsessive compulsive disorder. Anterior internal capsule, the medial forebrain bundle, is some German guys looking at that, and the singular cortex again, and then people have also looked at Tourette's syndrome. Tourette's syndrome, again, it's a very niche market because severe Tourette's is so rare that it's only half a dozen cases for the whole country. Although Tourette's itself, by that you mean the odd twit or the odd jerk, is actually quite common. Almost a variant of normal. Everybody will have the odd twitch from time to time. So I'll finish with some kind of thoughts on the future direction. So I mentioned the electrode design hasn't changed now for about 15 years. So now it is, and they're going to try to build segmented leads in a circumferential manner, and more of them, so not just 4 contacts, but maybe 8, maybe 16. You can then steer the current around by having independently controlled anodes and cathodes. You can consider whether you adopt current regulating system, which then means that you're transmitting the same amount of charge all the time. Or currently, a lot of them do it by keeping a constant voltage. And if the tissue impedance changes, then so does the charge going through, which means you have to reprogram them. And with that goes multi-channel devices. Rechargeable devices I've mentioned, and that allows you to put much more power through, as well as making it easier. There's a project called Brain Sensor, and that means that you measure down the electrode and you store the information within the pulse generator, and you can then come on and download it later. So you can imagine one ingenious idea was that you can look at somebody's activity and see what they're actually doing. So you can imagine that one of these in somebody on benefits would be a good laugh, wouldn't it? Say, actually, do you know what? Do you know what you were doing all day? We've been able to track where you are and what you were doing. We know exactly what you were doing. It was used more seriously for spinal cord stimulation, and you'd record the movements of the patient, whether they were standing or sitting, because it's a bit like, some of them have got sensors in, a bit like the iPhone, so you know which way up it is. And so you can work out whether a patient's in bed, up, and so forth. And one of the mathematical ideas they came up with was a variant of chaos theory, and that was that if your behaviour is random, you have a better quality of life than if it's fixed. If you like, the analogy is that if you feel like a cup of tea, you go and make one. So your cups of tea happen at random times during the day. If you're in an institution, you get your cup of tea at 4:45, whatever, because that's when you're born. So it's kind of, we're able to look at it that way. Can you put the whole thing in the scalp rather than this horrible tunnel down to just below the clavicle, which is a bit miserable for as a cosmetic place? And then there's a whole load of new targets and new conditions. So that there is almost, is there anything we can't target with deep brain stimulation? So eating disorders, addiction, and you can see that this gets a bit dubious now, so that if you have a serious drug addict and you could put a deep brain stimulator and stop their habit, that sounds great. But then you could apply the same logic to somebody who smokes. And by that means Tigger Aziz would have one of these to stop his kind of addiction to smoking. And is that ethical? And you're on kind of a bit of a slippery slope here, similarly with some of the eating disorders. And the Canadian lot put these into people who were morbidly obese to turn off their appetite. So they target an area of the hypothalamus. They didn't make much different to their appetite, but what they did find with this stimulation was it had improved their memory, and that then led them down the line of saying, is this something we could use for Alzheimer's? Which, again, these are kind of, to be honest, these are off-the-wall indications, but they're things that people are actually seriously thinking about. They're not kind of being treated in a completely trivial manner. And I was kind of making fun of the lot I was down with yesterday, which was a Nuffield bioethics lot. But actually, when you get into this, then the ethics of it could be a bit questionable. Whereas for the first bit of this about the Parkinson's and so forth, it's all pretty standard now and accepted and a big deal. And I'll just stop there.
Thank you, Paul. Questions for Paul? Ellen.
Did you measure the cognitive effects of the deep brain stimulation?
Sorry? Do we measure the cognitive stuff?
Yeah, because the
Yes.
have cognitive impairments.
Yeah, they do. They get part of the deal is that they get their neuropsych done first, and if their cognition is down or they're dementing or they have hallucinations, then we don't do that. And some of the stimulate one of the drives towards psychosurgery again is the observation that in many of the Parkinson's you do change their mood. You can have problems with depression, you can have problems with their behaviour. It's not really deep brain stimulation, but some of the dopamine agonists can get troubles with this compulsive gambling as well.
That's to me one of the most fascinating sides.
There is also a lot of concern about that, and it's like if you do the stimulation for this indication, then you don't have to worry about the psychosurgery aspects of it, but they're there almost whatever you do.
So does the stimulation improve when you're closed?
Sorry?
Does the stimulation improve?
No, it doesn't improve the cognition. And the cognition, as with any Parkinson's, really, it follows a downhill path. But it's one of the reasons to do it early rather than later. And once you think that somebody's becoming demented, then you just say, "I'm sorry, but this isn't going to work. It's not a good idea. I don't need to do it."
I've read that the placebo effect is quite common in Parkinson's disease, so the anticipation of treatment has improved the symptoms, so this idea that the reward pathway, I guess, is intact. So if the symptoms are going to go away when you turn the stimulator on, you get a release of dopamine and that. Have you seen that?
Not really, but a lot of the time this is looked at over a longer term. So you look at it over 6 months, a year, 2 years, and then out to the battery change, and over that period of time, you do get certainly it's called an impact effect. So when you stick the thing in, there's an impact effect for a period of time. And there are some groups that don't bother turning the stimulator on for about 6 weeks after the surgery. And now there is, again, it's one that gets into the ethical journals, but I think Canadian law did get as far as doing a sham burnhole. So they actually got as far as doing an operation, doing a burnhole, and not doing anything more. Whereas most of the other sham procedures, what people take the view is that they'll just not turn the device on. But for a lot of these things, you know when it's on and when it's off. So you can't really do the control experiment very well. But yeah, there's a lot of it's where these things start and stop. It's a bit tricky. And placebo responses, again, there's even argument as to whether it exists, which is an intriguing concept. It's all regression to me, is the argument.
I'm just wondering, as far as deep brain stimulation for pain, you say that early models obviously targeted sensory systems, and now the cingulate cortex is being targeted from an emotional point of view. There's been quite a bit of change and a lot of literature published in the last 2 to 3 years from the pain neuromatrix suggesting that it's a saliency system. Has anything been done trying to reduce the saliency of pain to improve?
What do you mean precisely?
Well, to make it so that it doesn't operate as such an interruptive function on the daily events. So that, because there's all these ideas around, the way that we test the efficacy of pain treatment is that you ask people to think about how much it hurts. But if people are distracted by pain, if people don't have if pain isn't causing them to be disabled as much, then
it's a bit like almost like quantum theories, and you don't know what it is unless you ask. So don't ask, and then you don't know.
But if it's not being reported as being a problem anymore, if you can reduce its saliency and make it so that it's not as disabling a function, then
a lot of the, I suppose this is kind of, I'll get shadowed by Helen back now, but a lot of the cognitive behavioural therapy and pain management programs almost work on that basis, that actually pain doesn't interrupt your daily functions.
Yeah.
And your measure is how well you do your daily functions.
Yeah.
Rather than, as you say, overtly, do you have pain or not?
Yeah.
Actually, you're capable of doing this.
Yeah.
This doesn't always work. There's one particularly irritating patient who wandered in, kept bleating about her pain, and then stopped her doing anything. And when I finally lost my rag, they said, "Well, you bloody well got here, didn't you?" This didn't go down too well. So they were a bit off put by that. But yeah, and I think it's very difficult to get for these things an objective measure that you can kind of repeat. And the pain matrix idea I thought was useful as far as it went, but it suffered from that problem that you couldn't then translate it into how much did this component quantify to your overall experience. And I think that, aside from the anecdotes, what you're saying is that problem, I think. It's difficult to quantify what's coming out of it. And if you can stop somebody's daily activity to being interrupted, so they're not disabled by the pain, and that's fine. But are they consciously aware of the pain, or unconsciously aware of the same sensation? I don't know. I think that's difficult.
Yeah. Just finally, do you see a future for deep brain stimulation, for the area that you've sort of skirted into but not gone into any depth, the psychosurgical stuff, altered personality? I remember it's the start of neuroscience this year, there were massive sessions on the use of singular deep brain stimulation with a phenomenal effect on intractable depression. By moving a couple of millimetres, you get another completely different effect of that stimulation. Is there something?
I don't know. I think there isn't a constancy to the literature.
There isn't?
No. And there are various trials that have gone on that don't seem to have reported overall in a kind of satisfactory manner. And the effect sizes that people were bandying about 3 or 4 years ago, I think Helen Mayberg's stuff on that must be about 10 years old now. As a concept, and you think that by now somebody would have got some solid data out of it, but it doesn't seem to have taken off. Perhaps it should have done, it's not. And that's a little bit odd. I don't know if that's just reticence on the part of psychiatrists and neurosurgeons to take this on. I think that there's a bit of, because we're neurosurgical, we're not that interested in, or we're not motivated to do it unless we've got an enthusiastic psychiatrist. So if we had a psychiatrist who said, look, come on, let's do this, I think we'd go and do it. But if the reaction from the psychiatry was, would they have difficulties supporting us or offshore or so forth, then we're not going to step over that bound, because we can put the electrode in, that's almost easy to do, but what we're not going to be able to do is to provide the expert follow-up and so forth, and manage the patient into longer term. That's much more demanding, and we don't have the training or the education to do that, even if we did have the time.
Which is why the focus has been on movement disorders. It's there and it's gone.
Yes.
That's it. Okay. Well, thank you very much, Paul.